Hi, everybody, and welcome. My name is Neil Seidman, and I'm co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And welcome to our webinar, which is called Overcoming Irritable Bowel Syndrome: Reclaim Your Life from Anxiety and Distress About IBS Symptoms. And our presenter is Dr. Melissa Hunt. Now, before we start, I'd like to just say a few words about ADAA, the Anxiety and Depression Association of America. ADAA is the leading nonprofit organization in the field of anxiety and depression. And our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, through practice and research. And we work to end the stigma and to get the word out. These conditions are common, they're real, and they're treatable. And I want to invite everybody to visit the ADAA website, adaa.org. It's really a wonderful resource. One of the things you'll find is a really great list of treatment providers. From the home page, you can just click on a link that says Find a Therapist. And in addition, we have a free peer-to-peer online support group that you can just click on if you want to participate. And finally, you can support ADAA by making a charitable donation. And again, from the home page, there's a link. Okay, so let's get started. I'm really happy to introduce our presenter. Dr. Melissa Hunt is a licensed clinical psychologist. She serves as the Associate Director of Clinical Training in the Department of Psychology at the University of Pennsylvania. She's a fellow and diplomate of the Academy of Cognitive Therapy. Dr. Hunt conducts research on the best approaches for managing stress and also into the causes and treatment of depression, anxiety disorders, and chronic GI disorders like irritable bowel syndrome, which is our topic here. In addition to her research, Dr. Hunt has a private practice where she specializes in the cognitive behavioral treatment of mood disorders, anxiety, obsessive compulsive and trauma disorders, and working with patients with GI disorders like IBS. And Dr. Hunt is the author of a wonderful self-help book, which is called Reclaim Your Life from IBS, a scientifically proven plan for relief without restrictive diets. So now let me turn things over to Dr. Hunt.
And here I am.
Well, welcome, and I so appreciate you doing this presentation for us.
Well, thank you so much for having me. I'm looking forward to it.
Great. So, a beginning question, how do I know if I have, if I have different digestive symptoms, but how do I know if I have irritable bowel syndrome? What are the main symptoms?
That is an excellent question because distinguishing IBS from other kinds of GI disorders is both a little bit tricky and very important. So here's how you know if you have IBS. The main symptoms of IBS are that you're going to have abdominal pain. We used to just call it discomfort, but now we really say it has to be pain at least 4 days per month or about once a week over at least 3 months. And we want that to be associated with one or more of the following, that pain is going to be related to defecation. So typically people feel the pain before defecating, and then after they defecate, they get relief, although it doesn't always work exactly that way, but that's pretty typical. And or a change in the frequency and or the form of stool. That is, in normal language, either you've got kind of chronic diarrhea, or you get constipation, or you flip-flop back and forth between the two. So sometimes you have terrible diarrhea and sometimes you have constipation, and it just sort of gets mixed. And we really want to see that after appropriate evaluation, the symptoms can't be fully explained by another medical condition.
So one of the main indicators that I might have IBS is that pretty common pain that I might be getting.
That's right. Abdominal pain, which can be either very crampy and kind of hot and urgent, or it can be more associated with sort of bloating and really feeling very distended and feeling like you just can't get the poop out.
Okay. And if I think I might have IBS, should I get a checkup with my doctor, or what should I do?
Yeah, you probably should. So there's a few other symptoms associated with IBS. Urgency in particular is very distressing to people. Fear of fecal incontinence, which is the technical term, but we all know what that means. It means actually losing control of your bowels or pooping in your pants. Lots of people with IBS also really struggle with bloating and gas and flatulence. I often have female patients tell me, I feel like I'm 6 months pregnant every time I eat a meal. And IBS can really impair your quality of life, secondary to lots of different things, especially fear of food, starting to feel like food is the enemy and really restricting your diet to a very narrow range of foods that feel safe, worrying a lot about sensations in your gut, worrying about being close to a bathroom that you're willing to use that doesn't have long lines. And sometimes it can even result in avoidance of travel or crowds or recreational activities, going to worship services, going to sporting stadiums or concert venues. Any place where getting to a bathroom might be tricky. So given how much distress and dysfunction IBS can cause, we really want to think about being sure that you have IBS. So what should you get tested for? Well, there's a couple of main things that you really want to make sure your doctors have ruled out. The first big category are the inflammatory bowel diseases. That's Crohn's disease, ulcerative colitis or UC, and microscopic colitis. And these are actually autoimmune disorders in which the body's immune system starts attacking the lining of the gut, which is not a good thing, obviously. And they have a lot of the same symptoms as diarrhea predominant IBS. You also want to be tested for celiac disease. Now, this is not sort of just, people avoiding gluten because they've somehow heard the gluten is bad for them, or because they might think they have an intolerance to gluten or that it's healthier to eat gluten-free. This is a true gluten intolerance. It's also an autoimmune disorder in which if you eat gluten, your immune system is actually going to attack the tissues in your small intestine. So you definitely want to get that ruled out. And then the final thing that you might want to rule out is something called bile acid malabsorption or dysfunction. And this often results from either an overactive gallbladder, which can be called Haber syndrome, where the gallbladder is just squirting out way too much bile acid into the gut, or if you've had your gallbladder removed for some reason. You can definitely have a situation in which there ends up, again, ironically, being too much bile acid in the gut. And sometimes people who have used non-steroidal anti-inflammatories for a long time, so that's ibuprofen or naproxen, common trade names for those are things like Motrin and Aleve. If you use those drugs for a long time, they can actually damage the lining of the small intestine, and you can end up with too much bile acid in there. those conditions are all easily treatable with something called a bile acid sequestrant. There are a number of different medications that do that. And if you have any of these 3 sets of conditions, then it really is important to have that be identified by a physician.
So this is a good place to start, is I just want to get screened to make sure I don't have these conditions.
Right. So what
Because
tests?
this is not the same thing as IBS. These are
That's right.
more
These,
serious, but I want to get screened to make sure I don't have it. So if people are taking notes, their doctor, likely already knows about all these, but the first category is the inflammatory bowel disease.
mhm.
And then the second category is celiac disease.
Yeah.
And then the third category is a little bit longer to write down, but it's bile acid malabsorption. How common are these more serious diseases?
Well, they're not super common in the population as a whole, maybe just 1 to 2% of
1 to
folks.
2%. Okay.
But in the population of folks who are presenting with chronic GI symptoms, so folks presenting with the symptoms of what might be IBS, the rates of these things are higher. They're more like 4 to 5%. So it really is
Okay.
important to get tested for these.
Yeah, so I definitely want to get screened for these as a starting point. Okay, excellent. Thank you.
So let's maybe talk about how you get screened for these things. The good news is you don't necessarily need to be scoped, which is something that most people are pretty anxious about and don't necessarily want to have done. For the most part, you can just do a combination of basic blood work and actual fecal tests to rule out these other disorders. Now, this is especially true, that if you have fever or if you have blood in your stool, which is really noticeable because like the water in the toilet bowl is really going to turn pink or even red. It's not just going to be a teeny tiny, smear on a piece of poop. It's really going to be there's blood in the toilet bowl. Or if you have unexplained weight loss or pain that wakes you up at night, then it's incredibly important to get these tests done because those are all signals that whatever's going on with you, it's probably not just IBS. So the doctor is going to want to do some basic blood work. They're going to look for a high white count, which is an indication of inflammation. They're going to want to check for anemia or other nutritional deficiencies like vitamin B12. They're going to want to check for celiac antibodies. Now note that you actually have to continue eating gluten for at least 6 weeks prior to having that test done, or it might end up with a false negative. And then finally, they're going to do some stool testing. They're going to check your stool for blood, but they're also going to do something called the fecal calprotectin test, which is actually a pretty sensitive test for inflammatory markers. Now, if that comes back positive, then your doctor's probably going to want to follow up with a colonoscopy or an endoscopy of some kind to confirm that diagnosis. But the good news is that most of these tests are really very non-invasive and you can just have it done at an outpatient testing lab.
Okay. So that's step 1, getting my screening with my doctor.
Mm-hmm.
Good.
Now, what ends up happening for most folks with IBS is that you have all that testing done, and sometimes you end up with a GI doc who really says, well, let's do a colonoscopy just to be on the safe side anyway. And all of these tests come back negative. Now, in a lot of ways, that's a good thing. That means you don't have one of these, potentially life-threatening disorders like an inflammatory bowel disease. But on the other hand, a lot of people with IBS get very frustrated when those tests come back negative because you're thinking, well, but something's really wrong. Clearly, my gut is not working the way it's supposed to. And so you're left wondering, what the heck is actually wrong with me? Because my doctor is saying there's nothing really wrong with my gut. Well, there is definitely something wrong. It's just that it's not in the actual tissues of the gut. It turns out that what's wrong is a little more complicated than that. So the first thing that we like to say about IBS is that it's a gut-brain problem. That is, there's something about the communication between the gut and the brain that has gone wrong somehow. Now, what's going on with that? Well, we have this thing called the enteric nervous system, which is actually the part of the nervous system that controls the gut and that gives the brain feedback from the gut. And it's got as many neurons in it as the whole spinal cord. So it's actually a pretty important part of the nervous system. And what ends up happening is that the enteric nervous system starts signaling to the brain too loudly. And then what you end up with is an experience of pain and discomfort that is out of proportion to what's really happening in the gut. So your brain is getting all these signals, all these pain signals, but there's nothing really wrong with the tissues. Now, if you don't believe that that can happen, I want you to think about phantom limb syndrome, because we've all heard about that in, our brave veterans who come back, who've lost limbs. One of the biggest problems that they face is something called phantom limb pain. So they may have lost part of a leg or part of an arm in an IED explosion or something, and yet they come in and they say, "Doc, it's like the hand is still attached to me and it's on fire. It hurts so much." Now we got to ask ourselves, where is that pain being experienced? Well, it's obviously not in the hand. The hand isn't there. So that pain is being experienced in the brain. And that's another kind of problem of centralized pain processing, where your brain is registering pain that's not informative about anything that's actually happening in the body. So that can be part of the problem. Another part of the problem is that we're learning more and more and more these days about something called the microbiome. And maybe some of our listeners have read some articles about this or seen something about this. The microbiome is all of the symbiotic bacteria that live on and in our bodies.
And there's a lot of bacteria that's in our digestive system.
There's trillions of them. In fact, there are more bacterial cells in our body than there are human cells, which is really hard to wrap your brain around. But usually we think of bacteria as being a bad thing, as something that makes us sick. But in this case, these are symbiotic bacteria that actually help us. And the majority of the bacteria in our bodies actually live in our gut, where they perform some incredibly important functions for us. One thing they do is that they're one of the front lines of our immune system. So we've got all these little watchdog bacteria that live in our guts that munch up and compete with and kill invading bacteria that we don't want in our bodies. So they're very useful little frontline soldiers that way. The other thing that the microbiome in our gut does is it helps us digest our food. And that's probably one of the most important things it does for us. And there's increasing evidence that folks with IBS often have what's called dysbiosis, or that is to say, the ecology of the microbiome, all the different species that are supposed to be in there, have gotten out of whack. So some of the species that we need have kind of died off, others have taken over. Think about a garden where you've got too many weeds and they're kind of out competing the plants that you really want. There's some pretty good evidence that a lot of folks with IBS have what's called dysbiosis, that the microbiome has just gotten out of whack. Now, when you put all this together, what you get is something called visceral hypersensitivity. So the viscera is the gut, and hypersensitivity is kind of obvious. You're too sensitive, right? So the pain neurons in your gut are transmitting way more loudly. You've got more gas and water in there than you're supposed to have. And what ends up happening is, of course, when you're getting all these loud pain, discomfort signals, people start to focus their attention on their gut sensations. And of course, as soon as you start focusing on something, you notice it even more, and you end up in this kind of vicious cycle of hypersensitivity and hypervigilance.
So let me see if I can understand if I have IBS. So I did my screening and I don't have anything, one of those really serious, potentially life-threatening conditions, thank God, but I have IBS. And what might be physically out of balance is what you call the microbiome.
Right.
but then also I have a kind of hypersensitivity where I'm experiencing pain, and it's a real sensation,
Absolutely.
but the pain really is not giving me accurate information
That's right.
because there isn't anything that's, yes, there's something out of balance, but it's not nearly as bad as it feels.
That's
You know,
right. That's
what's
exactly
happening.
right. So
Okay.
usually pain is really helpful. If you put your hand on a hot stove and you get a pain signal, it's telling you that there's tissue damage happening and you better take your hand off the stove. Unfortunately, the pain in IBS just isn't informative in the same way. It's not helpful. It's pain, it's real pain, but it's not telling us about any actual tissue damage that's happening. So it's just unhelpful pain.
Okay. Well, this so far is making me feel more reassured about IBS,
Mhm.
that it's not as physically a challenging issue as I thought it was. Yes, the microbiome is out of balance, but that physical pain is really out of proportion
That's
to
right.
what's actually physically out of balance.
That's right. And again, this is not saying that it's all in your head. A lot of it's in your brain, but we're not saying it's all in your head, right? Um, that IBS is absolutely physically real. The symptoms are real. You really are having either diarrhea or constipation. You really are having sometimes quite excruciating physical discomfort and pain in your gut. So the symptoms are very, very real. So that may leave people wondering, well, all right, what the heck can we do about this? Which brings us to stress. So stress definitely makes IBS worse. And lots of folks with IBS know that when they're super stressed out, their IBS tends to flare up a lot more often. And that's because stress triggers lots of biological processes that directly affect the gut. So again, it's not all in your head. Nobody thinks you're making this up. The pain is real. But partly that's because, the brain is actually part of the body, and things that we experience and think about and react to, the brain reacts to those things by triggering a whole cascade of neuroendocrine responses throughout the body that are going to have a direct physical effect on the gut. So learning how to manage stress effectively, but not to avoid stress, is super, super, super important. Sometimes GI doctors will say, you really ought to just, you ought to avoid stress because stress is clearly making this worse. Well, of course you can't avoid stress. Life sometimes is stressful. So what I really want folks to do is to learn how to manage stress a little bit more effectively.
So I'm not having to avoid things that are important in my life. Instead, I'm hopefully coming up with better ways of dealing with my stress.
That is exactly right. And one of the reasons that IBS is so distressing for people is that it often does lead people to start avoiding things that are really important in their lives. And that's just so unfortunate. So, yes, we really want to help people understand how to manage stress. So, let's turn to that. So, one of the first ways to manage stress is to learn some basic relaxation training exercises, because relaxation turns off the stress response in the body. And one of the best ways to do this is with deep diaphragmatic or belly breathing. Deep diaphragmatic breathing reduces heart rate and blood pressure and muscle tension. It suppresses the release of adrenaline and cortisol, all the body's stress hormones. And most helpful for IBS, it actually optimizes intestinal motility. It actually gets the muscles in the gut kind of contracting with peristalsis and so on to move the food along, but in a kind of optimal way. So it's not too tight and it's not too loose, it's not too fast, it's not too slow. So deep belly breathing, when done correctly, can really just kind of turn down the volume on the stress response in the body. So
So when
that's
I'm doing, sorry, when I'm doing belly breathing,
mhm,
so I'm breathing down in my belly and breathing deeply
right.
and maybe more slowly.
Way more
Yeah,
slowly,
way more
way more
slowly.
slowly.
Okay.
Lots of people, when they try to take a deep breath, they sort of get the upper chest and shoulders involved in the action, and and it sounds almost sort of more stressful. It sounds like that. And that's not belly breathing. Belly breathing, you want to really imagine like blowing bubbles or blowing through a straw. You want a nice, extended, slow, long exhale that might take, anywhere from 5 to 10 seconds even, to just exhale all that air and push the belly in, and then just sort of relax the belly muscles and take a big, deep inhale. Not a sort of tight one up in the shoulders and the upper chest, but a real slow one. There are videos online that demonstrate this. You can find things on YouTube. So it's really important to learn how to do deep diaphragmatic breathing kind of correctly, because that really helps turn off the stress response.
How many minutes, say I learn a pretty good belly breathing skill from one of these videos, how many minutes do I need to set aside to get some benefit from this, from belly
So
breathing?
the way I typically suggest that people in my private practice do it is that I want them to practice 3 times a day for a minute each time a day, and you want to get yourself down to a respiration rate of about 4 breaths per minute. So you want each breath cycle to take about 15 seconds. So that's 3 minutes total time over the course of the day. That's not much time. Most people spend way more time than that playing Candy Crush or checking Facebook. So just 3 minutes a day, 4 breaths at a time. That's it.
Well,
That's all
this
you got to
sounds
do.
like a really, really valuable thing to do in just a very few minutes to be able to have this much benefit.
Mm-hmm. And then once you get good at it and you've learned it, then if you're ever in a situation, where you're stuck in line at the supermarket and your gut starts to cramp, many people find that just taking 2 or 3 deep breaths, 45 seconds just while you're standing there waiting in line, is enough to get that cramping feeling to back off, and you can actually relax the muscles in the gut.
Very good.
So relaxation training is great. Another thing that I strongly recommend to people is exercise, because relaxation turns off the stress response, but exercise burns it off. So that whole fight or flight reaction in the body, that was designed over many millions of years of vertebrate evolution to help animals basically escape from predators. That's really what it's mostly there for. And this is a great system to have if what you're dealing with is a saber-toothed tiger, because you get all this adrenaline and cortisol and oxygen and glucose and, these things that just really fuel your ability to run away and save your own life from a, saber-toothed tiger attack. But it's not so helpful when you're sitting in rush hour traffic, or you're in a meeting at work, or you're stuck in line at the supermarket. So if you exercise regularly, and it doesn't have to be super vigorous, none of this high intensity interval training nonsense, just a walk, just, a relatively brisk walk for 20 minutes will really, really help to burn off all that stuff, and will just help people feel more centered and calmer and less tension and less muscle tension and less gut pain.
So here are 2 things I can start doing to help my IBS. Learning a belly breathing skill, and just even just a very few minutes a day,
Mhm.
and then adding some time to my day where I can at least do some walking or other kinds of would you say aerobic exercise is more
Yep.
helpful?
Yes,
Okay.
aerobic exercise is generally going to be the most helpful. You
So
got it.
walking, jogging, swimming, anything that's going to get my heart rate going. And so these are 2 things I could start doing right now
You got it.
to
You
feel
got
better.
it. Now, of course, that's not what most folks with IBS tend to do. Oftentimes, because this feels like a very physical problem, people are going to turn to medication. And there's lots of different medications that people might consider. But what I tell people is that really, in most cases of IBS, you do not need medication. Now, folks with constipation are often going to use stool softeners or stimulant laxatives, and these can be helpful at times for sure, especially if you haven't pooped in a couple of days. It's not a bad idea. But you want to be careful with those, because the stimulant laxatives can also trigger a lot of fairly intense cramping. And it's important to remember that it's it's normal. It can be within the range of normal to only have three or four bowel movements a week. So if you don't poop every day, you don't have to freak out about it and jump on top of using a laxative. Now, people with diarrhea often use antidiarrheal medications, things like Pepto-Bismol, things like Imodium, and those can be effective, but sometimes people who are worried about diarrhea will actually start pre-dosing before they go out for the day. Even if their gut's feeling okay, they might say, well, I have to take that 45-minute car ride today, or I know I'm going to be stuck in that conference call for a while, so maybe I better just pop a couple of Imodium before I leave the house. And this turns out to not be a great idea for a couple of reasons. For one thing, it keeps reinforcing this notion that there's something really wrong with you, and that can actually increase your visceral hypersensitivity. It can make the pain worse. And another thing it can do is set up cycles of alternating diarrhea and constipation. So you might take a couple of Imodium and then find that you don't poop for a couple of days, and now you feel really constipated and bloated and uncomfortable. So now you're going to end up using a laxative, but then that cleans you out too much and you feel really crampy and tired. So now you might use Imodium again. It's just a really terrible vicious cycle to get stuck in. Now, another type of medication approach that people with IBS sometimes try and that GI doctors will sometimes recommend is a dose of an antibiotic called rifaximin. This is supposed to treat small intestinal bacterial overgrowth. It really turns out to not be that helpful to a lot of people. And even if it works, most people find that it's temporary, and they may require retreatment as much as every 3 months. And the reason that it turns out to not be that helpful is because it's just like pulling up all the weeds in a garden, but not replanting anything else. So if you do that, what's going to happen is the weeds are just going to come back. So you may have a little bit of bacteria that you don't want in your gut, but the problem is that taking a broad spectrum antibiotic really just sort of kills lots of things, and it doesn't really do anything to reestablish the health of the microbiome. So while rifaximin may be helpful for a small minority of people, it's not something I really generally recommend.
So what I'm hearing about medication, this is so helpful. First of all, I guess for constipation, if I've gone a few days without having a bowel movement, then you're saying, well, you know what, this can be quite helpful sometimes to take a laxative, but not as an ongoing thing.
Right. Mm-hmm.
But then also what I'm hearing is that just in general, you're saying that medication is really not the best way of addressing IBS. And I'm wondering if this might be different from what a lot of people might hear from their general practitioner, because after all, MDs are going to be more medically oriented.
Mm-hmm.
And so I might get, is it possible a lot of people are going to be getting advice from their doctor to take these kinds of medications, and this may not be what you're saying is the best approach?
That's right, and that does feel a little bit confusing. Both general practitioners and gastroenterologists will often recommend many of these medications, mostly because they really want to give you some help. They want to give you some relief. They want to address your symptoms. But the problem, of course, is that addressing the symptoms doesn't really address the underlying problem, which is this brain-gut connection and this visceral hypersensitivity. So sometimes the more you address the symptoms, the less opportunity you have to address the actual underlying factors. And one of the things that's well known about irritable bowel syndrome, and that most GI doctors will tell you if you really ask them, is that traditional medical approaches really don't work all that well for IBS. You may get relief on day 1, but on day 10, things are just as bad and maybe even worse. Now, there is one sort of way of approaching IBS with medication that does have a little bit better evidence base as being more helpful long-term, and that's using a class of medications known as neuromodulators. Because remember that it's the nervous system, it's the way the enteric nervous system and the central nervous system, the brain, are talking to each other, that's a big part of the problem here. So using medications that actually modulate that crosstalk between the brain and the gut can be more helpful.
Do doctors know this, what you're
Mhm.
saying?
Some doctors do. Certainly, lots of GI doctors will recommend these neuromodulators to patients. Now, sometimes people are reluctant to take them because they do also go by other names, these medications. Sometimes they're referred to as antidepressants. And when the GI doctor suggests, well, I think you should just take one of these drugs that's an antidepressant, sometimes people feel like they're being told they're crazy. And that's a very uncomfortable conversation to try to have with your doctor. But the thing to understand is that these medications modulate nervous system activity throughout the body. So think about aspirin for a minute. Aspirin can be used to reduce a fever. It can also be taken to make your headache or your muscle pain go away. And aspirins also work as blood thinners, right? They can be often prescribed for people who've had strokes. So if you had a terrible headache and somebody said to you, okay, I'm going to give you a blood thinning medication now, you'd look at them like they were crazy. Or if you had a fever and somebody said, okay, I'm going to give you this medication now that's really, really good at reducing muscle pain. Again, you'd look at your doctor and you say, what the heck are you talking about? I don't have muscle pain. I have a fever. But the interesting thing is that, of course, aspirin does all of those things. And we don't tend to refer to aspirin as an antifebrile or a blood thinner or an analgesic. We just call it aspirin. And everybody gets that aspirin can be used for all these different things. Well, these medications are very similar. They modulate the nervous system activity throughout the body. And all of these medications, the tricyclics, the SSRIs like Prozac and Zoloft, and the SNRIs like Effexor, Pristiq, and Cymbalta, can all be very, very helpful for people with IBS.
And this goes back to when you were first explaining what is going on with IBS, is that a big part of it is the communication between the brain and the gut, where I'm experiencing a lot of pain that is really not accurate in terms of what's actually happening in my body. But I mean, it's a real sensation, but it has
That's
to do with
exactly
that.
right.
And so the neuromodulator category of medications could be helpful.
That's exactly right. Now, unfortunately, this is, of course, not what most folks try, and it's not the sort of first step that most doctors recommend. Usually, doctors are going to suggest an elimination diet to see if you can identify foods that are triggering your IBS. And in fact, we know that elimination diets are the most popular approach to managing IBS, and they're the things that most folks with IBS are going to try. And what you can see on your screen here is just a couple of quick screenshots of some of the many, many, many diet books that are out there that you can buy on Amazon or, at your local bookstore, that suggest that if you just change your diet, you're going to change your life, that your IBS is really going to get better and go away. And here's the truth, folks. Unless you have celiac disease, there is no reason at all to avoid gluten. You do not have to have a gluten-free diet if you have IBS. Avoiding gluten has lots and lots of downsides. It's actually fairly expensive to buy the special gluten-free foods. It can be quite inconvenient. You may lose a lot of your favorite foods. And it's actually really hard to be truly gluten-free because there's hidden gluten in a lot of different products. So if you have celiac disease, then you absolutely must avoid gluten. It's a medical necessity for you. But if you don't, there's really no reason to limit or avoid gluten in your
Now,
diet.
how common is that celiac disease, which was one of the items that I'm supposed to screen for right at the start, is not very common, right?
No, celiac disease is not very common in the general population, but some studies have shown that folks presenting with IBS-like symptoms, when you actually screen those folks for celiac disease, you're going to get about 4 to 5% of those folks testing positive for celiac disease.
Okay.
So it is important to have that blood test done and to establish whether you have celiac disease. But again, if you don't have celiac disease, there's no reason to avoid gluten.
Now,
Another
if I'm in the other 95%, so I have IBS, I've been screened, I don't have celiac,
Mhm.
but I hear all this information, in the media and advertisements and even, health advisors saying it's better to avoid gluten.
Mhm.
So where is all that coming from? Why is that so prevalent in our
Well,
media?
to be a little cynical about it, I think it's because General Foods can make a lot of money selling gluten-free products to people. I think that there's a big financial incentive for the industrial food complex to market this stuff and to push it pretty heavily. Um, the agricultural revolution back in Egypt about 10,000 years ago brought grains to us, and there are people who argue that maybe that hasn't been great for public health, but by and large, the vast majority of people can digest gluten with no difficulties whatsoever. So it's sort of a fad, and it's driven by a lot of marketing, but there's really no reason for the vast majority of people to avoid gluten. Dairy is another thing that has become a sort of fad to avoid dairy. And again, unless you have an actual milk protein allergy or severe lactose intolerance, there is no reason to avoid dairy. And even people who are lactose intolerant can usually digest yogurt and cheese and kefir and buttermilk and lactate products just fine. Um, Again, around 10,000 years ago, human beings developed a mutation that allowed us to continue to digest lactose into adulthood. Um, so we did, in fact, evolve to eat cow, sheep, and goat milk because it turns out to be really adaptive. Milk is a wonderful way to turn otherwise indigestible grass into a very tasty, versatile, and complete protein for humans. And there was actually a genetic mutation that arose in a number of different human populations that allowed us to digest milk. So there's really no reason for most people to avoid dairy.
Now, I've
And
heard that yogurt contains a lot of healthy bacteria. Is that
it,
true?
it sure does. It sure does. Yogurt is a wonderful probiotic food that contains in it a lot of the bacteria that we need in our microbiome. So, in fact, yogurt and kefir, which are both fermented products, are actually pretty wonderful ways to reduce dysbiosis and increase the diversity of our microbiome.
So eating yogurt and kefir could actually help my IBS.
That's exactly right. It can actually help. And you'll notice that lots of yogurt products, in fact, advertise themselves as having active strains and lots of probiotics. And really, that may be a marketing thing, but it also happens to be true. So that one's a good one to follow up. Basically, we just really don't want people fearing and avoiding food because fearing and avoiding food really reduces quality of life and reinforces the feeling that you're sick, and it increases visceral hypersensitivity and anxiety. So we really want people to not be afraid of food. Now, I got to say a few words about the low FODMAP diet because this is one of the most sort of extreme and popular diets for IBS right now. It is the most restrictive diet of all. It is eliminating what FODMAP stands for up at the top of the screen is fermentable oligo-di-monosaccharides and polyols. Now that sounds like quite a mouthful. These are long-chain carbohydrates that are co-digested by the bacteria in our microbiome. That's what fermentable, that's what the F in FODMAP actually stands for. These are all the prebiotic foods. They're the foods that nourish the bacteria in our microbiome. And it includes a very long list of things: all dairy, all legumes, beans, soys, lentils, peas, chickpeas. So this diet is almost impossible to follow if you want to be a vegetarian because you can eat meat on the FODMAP diet, but dairy and legumes are right out. Wheat and barley and rye are eliminated, not because of the gluten, which is a protein, but actually because of the carbohydrate chains that are in those grains. Everything in the onion family, onion, garlic, shallots, scallots, everything in that family is right out. Not allowed to eat that. A lot of vegetables are out. A lot of fruits are out. Even apples. Lots of people like to eat applesauce when they have terrible diarrhea. Nope, not on the low FODMAP diet. So it's an extremely, extremely restrictive diet. So these are the prebiotic foods. Why is it helpful to eliminate them? Well, it's helpful to eliminate them because when foods are fermented by bacteria in our gut, they do cause more gas and water content in the gut. I mean, everybody knows that beans make people gassy, cauliflower and broccoli can make people gassy. They do. These foods do that. They increase the gas and water content in the gut. But they do that for everyone, and they do it for everyone equally. It's only a problem if you've got visceral hypersensitivity. Now, I should say the FODMAP diet does have some good data behind it. There's good evidence that restricting high FODMAP foods does indeed reduce GI discomfort for many people with IBS. But what people don't always understand is that you're only supposed to follow the most restrictive part of the diet for 6 weeks, and then you're supposed to start reintroducing these foods anyway, because living on a truly restrictive high FODMAP diet is a terrible idea. It's really, really hard to get good nutrition on it. It's extremely difficult to maintain. It's almost impossible if you don't control your own food, like if you're a college student and you're eating in the cafeteria. And forget about eating out or at anybody else's house. Can you imagine, going to someone's house and saying, oh, and by the way, I can't eat any grains and I can't eat any legumes and I can't have any dairy. So, if you could make me a meal that follows all these rules, that'd be great. Most people aren't going to do that. So it really restricts what you can eat and where you can eat. Not only that, but the long-term effects on the microbiome are kind of worrisome. For example,
Because these are prebiotic.
These are prebiotic foods. That's right. These are the foods that feed bacteria that live in our gut. So if you eliminate all of those foods, you starve all of the bacteria that we actually need. So for example, we know for sure that the bifidus bacteria die out. Now, if you think about yogurts, a lot of them specifically advertise that they have bifidus bacteria in them because bifidus is one of the key microbiome bacteria. Well, if you starve them, they die and you end up increasing dysbiosis. So the real problem with the FODMAP diet is that it's an avoidance strategy. It's a strategy people use to try to avoid or eliminate the sensations that people with IBS are hypersensitive to. But this is not the approach that we really want to take. This is not a good long-term approach. A much better approach is to eliminate hypersensitivity because that's the problem. And the good news is that there's a way to do that.
So before you go on, just what I'm hearing about FODMAP is that it's this huge amount of effort which could be successful in the short term at reducing my symptoms, but is not addressing my problem. And over time might even be making it worse, just like the same idea with the medications.
Bingo, you got it. That's exactly right.
Okay, so now I want to hear, how do I get better? How do I overcome this?
How do you get better? All right. Yeah. Well, first we got to reduce your fear of food, right? And, this is often inadvertently exacerbated by doctors and nutritionists because the doctors will, tell you that, well, they really want you to try an elimination diet and then try reintroducing things and see what makes it worse. These beliefs that I have up on the screen are a lot of the kinds of beliefs that people with IBS sometimes have. That food just starts to feel like the enemy, and that's just no fun. So we really want to remind people that there are no universal trigger or danger foods, and what we really want is for you to get back to a healthful, varied diet with plenty of soluble fiber and some insoluble fiber, like the stuff that's found in leafy greens, and that's really going to be important to successful treatment. So stop so assiduously restricting your diet. That's super important.
So soluble fiber, would that be like oats?
Yep, there's a lot of soluble fiber in oats and in the flesh of most fruits and vegetables. So the skins of fruits and vegetables may be insoluble, but the flesh will be soluble fiber. Rice has a lot of soluble fiber. Berries, actually all of the legumes are packed with soluble fiber. So there are lots of easy, good ways to get soluble fiber in your diet.
And that's going to help with my overall system, digestive system.
It is going to help with your overall digestive system. It's really just, it's really a sort of a a diet for just good general health. It's going to help with, cardiovascular issues and all kinds of things if you just eat a varied whole foods diet. My general rule of thumb is that you want to have in your supermarket cart, you want about half the things in your supermarket cart to have only one ingredient. Just one. So broccoli, rice, chicken, collard greens, tomatoes, milk, things like that. Really just one ingredient. And then a lot of the things in your cart then may have, let's say 3 ingredients. And then you want to have very, very few things in your cart that have more ingredients than that. And you want to make sure that all of those ingredients you could also buy as single ingredients. So really try to avoid highly prepared processed foods. It's kind of a good rule of thumb. But let's move on to talking about cognitive behavioral therapy and gut-directed hypnotherapy, because those really, beyond sort of getting back to eating a healthful diet, those are the things that are really going to help reduce visceral hypersensitivity and central pain processing. These are the 2 approaches that are the most empirically supported, that have the most scientific evidence behind them, and that really have been shown to reduce the suffering of IBS long term without having to be terrified of food and really, reduce what you eat. So gut-directed hypnotherapy does work for sure. There are practitioners who are certified in that. I'm going to be focusing more today on cognitive behavioral therapy. So let's get into some of the details of that. So how does CBT for IBS work? So here's how it works. Well, first, of course, we start with relaxation training and encouraging exercise. Those are great to turn stress off and burn stress off. But wouldn't it be better to stop stress from starting? So there's where we really start teaching people what's called decatastrophizing. And I'm going to get into a little bit of the details of that in just a minute. And we want to get you exposing yourself to things. We want you to stop avoiding feared situations, feared foods. And this is the tricky part. We even want you to stop avoiding those feared sensations, because the more you avoid them, the worse they get.
So this idea of exposure really it sounds the opposite to if I'm using medications to try to reduce my symptoms, or I'm going on these very restrictive diets to try to have less gas. Uh, what is the idea of exposure? Why is that? How is that going to help me?
Right. So this seems really counterintuitive. I understand that. Exposure works because what is really pushing a lot of the visceral hypersensitivity is the very fact that you're so scared of and avoidant of and hypervigilant about those sensations. When you actually start exposing yourself to things, it turns out they become less scary and less painful. It's not that what we're suggesting is that we want you to tolerate terrible pain. It's that we want you to actually expose yourself little bit by little bit so that it stops being so painful. We're going to sort of turn down the dial on that connection between the brain and the gut to get the brain to stop registering all that pain so loudly and with so much discomfort. So let's go through this a little bit step by step. So catastrophizing. IBS patients often catastrophize GI symptoms. So there's a lot of kinds of thoughts that people might have, right? You fear the sensations, you fear what the sensations might mean. It's really hard not to think that there might be something really wrong with you and the doctor just missed it. It's really hard not to have scary thoughts. Like sometimes folks with constipation start having thoughts like, well, what if my gut just backs up completely? What if the system just shuts down and I actually need surgery? What if I die? What if I can't eat? What if my diarrhea is so terrible and I start losing too much weight? People get really, really, really worried about the pain. Even when your GI doctor has told you, I promise you there's nothing wrong, this is just IBS and it's really not going to hurt you. Sometimes it's hard to believe that.
So what I'm doing is I'm taking that very real sensation of pain, which you explained right at the beginning, is a big part of IBS, that I'm experiencing pain that's really coming from a miscommunication between my brain and my gut. But then I'm
Right.
taking that pain and I'm catastrophizing and thinking, oh, this means something really, really dangerous for me.
That's right. And that's a stressful thought. So, of course, having that stressful thought ironically makes the pain worse. I mean, it really is sort of a catch-22 here. The other thing people catastrophize about is what I like to call the social and occupational implications of having GI symptoms. And this really hits a lot of folks with IBS too. They worry a lot that they're not going to be able to go out, they won't be able to enjoy themselves, they won't be able to eat or drink, no one's going to understand. Many people with IBS are very ashamed of the problem, and they don't want to tell people why they have to go to the bathroom, and they say, people are going to think there's going to be something really wrong with me. People are going to think I'm gross or disgusting. This is just going to be a disaster. And so often people simply stop going out as a result. And that's really tragic. One of the biggest fears that a lot of people with IBS have is fear of incontinence, fear that they're actually going to not make it to a bathroom in time, and they're going to poop in their pants. They're going to lose control of their bowels. And ironically, sometimes even people with constipation are worried about this, because when the urge to move your bowels finally does hit, sometimes it's very intense and it feels very urgent. So I actually did a study last year. People used to ask me, well, how many people with IBS actually experience incontinence? And amazingly, we didn't actually know the answer to that. So I did a big representative study last year and found that all told, a little over half of patients with IBS have experienced at least one episode of fecal incontinence in their life. Now, often this was at the outset of the illness. They might have had a round of food poisoning or something like that, but now they live sort of in terror of it moving forward. About 20% of people with severe IBS have experienced more than 5 episodes. Now, there is no doubt that fecal incontinence is troubling, and it should certainly be discussed with your doctor. In some cases, there are pelvic floor exercises and biofeedback that can help. But here's the real key. Quality of life is far more affected by fear of food and anxiety and catastrophizing than it is by fecal incontinence itself. And I'm going to share a little secret now, which is that I actually have myself experienced 2 episodes of fecal incontinence in my life. One when I was in high school and I had gone hiking in the mountains and stupidly picked up a Giardia infection by drinking untreated stream water, which I don't recommend. And another in adulthood when I had been taking ibuprofen for a little too long and developed some bile acid malabsorption. And it was a little embarrassing and a little difficult to handle, but it certainly didn't end my life. And it certainly is something I think about every once in a while, but not a lot. And I don't catastrophize it. So I really know what I'm talking about here, that you can experience fecal incontinence and not have it sort of ruin and limit your life.
So it isn't the catastrophe that I might have thought.
That's exactly right. Exactly right. I once knew a lady who told me that, a patient who told me that if she ever experienced fecal incontinence at work, she would clean out her desk, quit her job, and never go back that very same day. And I thought, well, that would be a catastrophe because now you'd be unemployed. So really, that would be the catastrophe. And I really had to work with her to help her understand that perhaps it wouldn't be quite as bad as she had feared. So decatastrophizing these things is really important. And obviously, IBS itself can become a stressor. So, imagine that I were giving this talk in public in front of a big audience, and I'm thinking to myself, oh my gosh, if my gut acts up, I'm not going to be able to function. I'm going to have to run to the bathroom. People are going to think I'm incompetent. My talk will be a failure. I'll be humiliated. Giving a talk is stressful enough without entertaining those kinds of thoughts. And of course, as soon as you entertain those kinds of thoughts, oh my gosh, that's going to make you even more anxious. So this is the model that I like to use to think about this. You might have an initial GI sensation. You might feel a twinge or a gas bubble or feel a little bit crampy. And then you have a whole lot of negative thoughts. Oh no, not again. This is awful. Here it comes. I can't stand it. I'm going to have to leave. This is really terrible. Well, as soon as you have those thoughts, you start to feel really anxious and upset and frustrated and embarrassed. And it focuses your attention even more on those GI sensations. Well, what does anxiety do? You get increased fight or flight, right? Increased sympathetic arousal, which is your heart rate and blood pressure and respiration are going to go up. You get that whole endocrine soup going. And guess what? It makes your GI system even more uncomfortable. You start to feel more crampy, more urgency, more discomfort, worsening GI symptoms, increased visceral sensitivity, and we're really off to the races on this. So here's how we want to cut it. Deep breathing is going to cut it here, right? That deep diaphragmatic breathing is going to reduce all of that fight or flight stuff that's happening, and it will help some of the crampy feelings in your gut go away. Here is where we reduce with decatastrophizing, right? Well, all right, so I have to step off the stage for a few moments, run to the bathroom, and then come back. So what? We'll manage, we'll make it work. It's not a catastrophe. And ultimately, we want you to be able to have that initial GI sensation and think to yourself, so what? No big deal.
I don't have to limit my life, and my life doesn't have to be dictated by my IBS.
That's exactly right. And it's limiting your life that can really, really reduce quality of life for IBS patients. Because all that worry can cause a lot of avoidance. If you're worried about finding a bathroom, if you're worried about incontinence, if you're really worried about just the discomfort from your constipation, and you just think, I'm just not going to be able to enjoy myself or function effectively, so maybe I should just stay home. And people with IBS start avoiding lots and lots of things to the point where you can actually be diagnosed with agoraphobia. So avoidance of places in which having these symptoms or worrying about incontinence might get you to a place where you're actually avoiding living your life. And that's really the tragedy. So any place that might trigger an attack, any place involving food or drink, any place from which escape to get to a bathroom might be difficult. I've had people tell me they haven't been to any of their kids' athletic events or games. I had one patient tell me that she turned down free tickets to a baseball game that her son would have loved to have gone to. Another patient who had concert tickets to a concert she was so looking forward to, but when her gut felt twitchy that day, she thought, oh, I better not. And she ended up giving the ticket away to a friend and was so sad about it. So we do not want folks to keep avoiding. Even subtle avoidance can be a problem. Checking out bathrooms, scoping things out, always sitting in the back or on the aisle, planning your routes to the bathroom, wearing loose or comfortable clothes that won't press on your belly at all to increase discomfort. All of these things might seem really sensible, but they really backfire. They really backfire because they actually keep you focused on worrying about your gut and on any and all gut sensations, and they increase hypervigilance and they increase visceral hypersensitivity. So, what do we want you to do? What we want you to do is exposure therapy.
Now, is this part of the cognitive behavioral approach?
Yeah, it sure is. This is a big part of both. It's behavioral because we want you to actually change your behavior and start doing stuff that you've been avoiding. And it's cognitive because doing that exposure therapy is going to help you change your beliefs about your IBS symptoms. It's going to help you decatastrophize. And ultimately, these things are going to actually reduce visceral hypersensitivity. We know this. We know this for a fact. We can measure this. It's been looked at in studies. And we know that when people engage in a therapy that involves exposure therapy, which it's worth pointing out, gut-directed hypnotherapy, the other main therapy I talked about, actually still gets people very much focused on the sensations in their gut. You just start thinking about them a different way. So when you're doing gut-directed hypnotherapy, you're still visualizing and focusing on those sensations in your gut, and you're trying to sort of reinterpret them and use imagery and so on to make them feel different, but you're still very much focused on actually experiencing those sensations. So exposure therapy for IBS works just like exposure therapy for something like a snake phobia, right? Somebody who's really terrified of snakes. You're not going to start out by wrapping a python around their neck. You're going to start out by just maybe looking at pictures of snakes and think until that feels comfortable. And then maybe just looking at a very small snake in a glass cage sort of from across the room until that feels comfortable. So you want to create what's called an anxiety hierarchy. You want to make a whole list of things that, you know, from the most anxiety provoking down to the very least anxiety provoking. And then you work your way up the list very slowly, carving things up into small manageable chunks. So if flying to California to visit, you know, your daughter feels totally unmanageable because you can't imagine being trapped in a plane for that long, we're going to start really small. You know what? Go drive around to the block in your neighborhood for 30 minutes. Just be in your car, sort of driving around, but you're never more than a few minutes from home. If that feels too hard, just sit in your car in the driveway until you feel bored, because bored and anxious are kind of like opposites of each other. I know this sounds crazy, but it really, really works. So the final piece that we might want you to also engage in is what are called behavioral experiments, which can also really help you stop catastrophizing and avoiding. So for example, lots of people are really, really worried that if they go to a movie or a concert or they go to a place of worship, they think to themselves, well, what if I have to get up halfway through and go to the bathroom? I'm going to really bother everyone around me. It's going to be really noticeable. I'm going to be embarrassed. That's just a terrible thing to do. So what I suggest to people is, well, you know, why don't you go to the movie theater, buy a ticket to something, and go just sit in the back of the theater and just count how many people get up and come back. It turns out lots of people do that. And it's really not a big deal. Or, you know, go ahead and sit yourself in the middle of the very center aisle, and at some point in the movie, get up and excuse yourself and really try to pay attention to how people react. You know, most people are just going to shift their legs over very politely and let you pass. It's just not that big a deal. So really
this is another
testing.
example of I'm decatastrophizing.
That's exactly right. But it's actually, rather than just sort of sitting at home and being up in your head and thinking, well, is there any way to think about this, other way to think about this, you actually go and you test it out in the real world. So another one of my favorite examples is, you know, being really worried that your coworkers are going to think you're really disgusting or weird if you tell them that, you know, you have chronic GI issues and you just might need to use the bathroom more frequently. So let's say, you know, you have to be in a car with your boss and a couple of coworkers going to an off-site meeting, and you're like, oh my God, what if I have to ask them to stop, you know, halfway there, even if it's only been half an hour, so I can use the restroom at a, you know, at a restaurant or something. Just try telling somebody and see how they actually react. Most people are really curious, compassionate. They're going to be glad that, you know, that you trusted them and that you told them. And they're going to say, oh, okay, good to know, no big deal. A few people may ask you for more details because they're concerned about you and they care about you. Most people are going to say, all right, well, thanks for telling me. Fine, let us know if you need to stop. And it's just not that big a deal. So trying these kinds of experiments where you carve out something that feels a little bit safer, a little bit more doable, is a really, really wonderful way to change your catastrophic beliefs about IBS and help you be more comfortable.
Very good. Very interesting.
So in the end, if you can pull all this off, you will actually reclaim your life from IBS. And that's what I so want people to be able to do. Not let IBS stop you from living your life to its fullest.
Well, thank you so much, Dr. Hunt, for your presentation. And I want to thank everybody for watching the webinar. And if you want to advance the slide if you can. So I want to let everybody know, of course, about Dr. Hunt's book, Reclaim Your Life from IBS. And if you have questions that you'd like to send in, Dr. Hunt is available to periodically address questions. You can just send your question to webinars@adaa.org. And if you want to put in the subject line Dr. Hunt or IBS. And again, thanks again for watching, and we'll see you next time.
Thank you, everybody.